Welcome to the Oncology Podcast. If you enjoy today's edition and would like to subscribe, head over to oncologynews.com.au and subscribe to our newsletter for regular podcast updates and a weekly review of the oncology news from Australia and around the world.
Hi, this is Rachael Babin from the Oncology Podcast. Today I'm talking with Professor Eva Segelov with an update on cancer and COVID-19 in Australia. Eva is a medical oncologist and Director of Oncology at Monash University and Monash Health. Thanks for listening. Perhaps we can start with an update on how things have been going for the last 2 weeks since we spoke and how things have changed in your practice.
Thanks, Rachel. We're not really where we thought we'd be, and that's very, very good news, but has left a lot of us really puzzled about what to do next and what will happen in the future. So in Australia, we always thought we were 2 to 3 weeks behind the horrors of Europe, the UK, and then the US. But almost every country had entered this stage of overwhelming health services, huge impact on staff, either from being sick or in quarantine, and then subsequent impact on non-COVID-19 services, particularly cancer. And I was watching an interview with a British oncologist talking about how no services could be delivered in many places due to this absolutely overwhelming influx of very sick patients. Here in Australia, we had extra time to prepare for that, but everybody was expecting it to come. And quite thankfully, it has not come, nor does it look like we will get that huge influx to the point of overwhelming the hospital system. Australia's controlled the pandemic very successfully using the principles of social distancing and also testing and tracing contacts. Most of our cases were imported from people coming back from overseas, so strict quarantining has had a real impact. What we don't yet know is the amount of asymptomatic infection and asymptomatic transmission. But Australians also have been particularly good at lockdown, despite some reports of Bondi Beach and St Kilda Beach being chock-a-block full. And it was very impactful that a couple of weeks after the Bondi Beach story, we saw a big rise of cases in Bondi. So all of that, I think, has helped keep our patients safe and our cancer patients very safe. And that's really a wonderful thing to see. In Australia, most cancer services have continued to deliver treatment as required. There has been some trimming and rationalisation of treatment. Perhaps people were given treatment breaks where in an epidemic they would not have been. People have been transferred from, say, intravenous trastuzumab to subcutaneous to be given at home by hospital in the home services. So all of those transitions we were preparing for and started to make last time we spoke are now in place. We're still concerned about patients needing to come into hospitals. There are more and more reports of how the virus lingers, not only on surfaces that are cleaned, but things like air vents that may not be cleaned, about how quickly the virus can spread through wards of hospitals. We found that the uptake of the video conferencing component of telehealth has been challenging, and certain populations obviously find it more challenging than others. There are people who don't have mobile phones or home phones or access to computers, etc. And so we're hoping to do a project where we actually give people equipment and training for free so that they can access these services. So our principles of still trying to keep patients at home under quarantine continue. But the community transmission rate appears to be very low. And as healthcare workers, we feel safer going into hospitals and we feel safer than we did for our patients continuing vital treatment.
It's really important to have that security, though, as best you can, to feel as as safe as possible. And I think Australia is really well placed with the actions that you've been taking to prepare compared to, for example, as you were saying, the UK, where I think the NHS was already so overwhelmed. And it really is like this was not needed. They were already in crisis mode across some parts of the country. Talking about safety, I think that's definitely an important issue to address. Do you think that PPE and staff safety is a big consideration for your staff at the moment, or is that abated a little now?
No, there's still front page reports on various health services not having adequate PPE or various whistleblowers stating that the PPE is not adequate. One of the areas of confusion is that there's not really a uniform recommendation. It's been health service by health service, and there's been quite a lot of vocalisation to try and make that standard. It shouldn't be different from one hospital to another. There's confusion about whether we should be wearing masks when we see our patients. There's confusion about people in the street, whether they should be wearing masks. And as more information comes out about this virus, it seems that it is transmitted in an aerosolized way. However, again, that's going to be quite different in an area of high community transmission versus an area of low community transmission. So PPE and healthcare worker safety remains a huge issue. We want to be prepared. We don't want to be caught out like other jurisdictions have. Healthcare workers want to know that their safety is paramount. We are assured by our hospital administrators that that is so, but it's still a big story in Australia.
Yes, it's a big story everywhere, I think, the inadequate PPE and also this massive confusion around masks. Do you think, comparing Australia to China, Italy, Spain, do you think that we have dodged the bullet?
I think there's very good evidence that the curve has been flattened, but of course it depends how you test and who you test. Nevertheless, all of the experts in the epidemiology, and I'm certainly not one of them, I'm a voracious listener, there is very much evidence that the pandemic has been controlled, which has obviously then led to the next question about how quickly we can take the brakes off, how we then have an exit strategy for the pandemic. So it's one thing to lock down during a time of crisis or to prevent a crisis. And there were certainly not many questions asked about the need to prevent what was going on in New York or the UK or Northern Italy. But the questions are now being asked about how do we exit from that? And that's in the general community and the economy, and also in the hospitals as far as restarting elective surgery, reopening breast screen, etc. And along with that has been a focus on what is the opportunity cost loss from shutting down screening, delaying non-urgent surgery, which I saw pointed out is actually quite urgent. It's just that it's not immediately life-saving at this very moment, for example, like a major trauma surgery would be. What is the impact down the track? And in fact, many of us are now expecting that there'll be a period of increased number of cancer diagnoses made because of this delay of people not seeking diagnoses or tests or having procedures during this acute phase. So we're actually expecting demand to go up as the brakes come off. And that's a challenge for the health systems as well, because it was in some ways quite easy to commandeer resources for a COVID response. We now need to have an equal process to address the catch-up phase of more people coming in once restrictions are lifted.
Yes, you can certainly understand the psychology of someone who might have a symptom, might be fairly vague, might be feeling tired or bloated or a gastro symptom, and they don't want to go to their GP. It's the last place they want to go and start an investigation. So yes, it's interesting about allocating those resources because there are going to be spikes in specialty areas because people have been avoiding getting that advice and starting the process.
It will, and because there's been enormous resources put into the COVID response, everything from buying thousands of ventilators, training, PPE, we're expecting that the health budget for the remainder will be quite restricted. So where we're already in a system of restricted health budgets, the impact of what this epidemic has cost in financial terms, let alone, of course, human terms, may impact on cancer patients and other patients with less money to go around for usual type care.
Yes, I think it's interesting, isn't it, that the result by the end of the year may well be that more patients are diagnosed at a later stage, and the impact of the delays and the interruptions to the health service and those services that desperately need the money to kind of redress that balance aren't going to have those resources. Yeah, not easy decision making.
They're not worse than an uncontrolled COVID-19 pandemic. That's without question.
Of course,
And
yeah.
we've seen that even countries where they've initially didn't lock down, go to lockdown because of this huge transmission, because of the highly infectious nature of the virus. So there's no questioning that we had to have the measures that were taken. And it's a little bit false when some economic or other commentators say the consequences may be worse than the disease, because the disease would be way worse if we hadn't done the lockdown. So was never a trade-off between the two things. Nevertheless, we're now in the situation where the lockdown's been quite successful. We have to work out for the community, for the patient community, healthcare, how do we revert slowly to some sort of semblance of normality without risking the pandemic becoming out of control?
Yes, and I guess it is a nice problem to have, how to dial back from preparing for the worst.
One interesting area is radiation oncology, where there was quite a lot of formal moves to restrict the time course of treatment and switch to different scheduling. And people are very interested to see if we will revert back to longer scheduling, or if in fact some of these shorter schedules will stay as standard. So watch this space for, in particular, to do with radiation and dose and duration of treatments.
Yes, that will definitely be something that's very interesting, and we'll keep our eye on that. It'll be fascinating to see how these impacts do translate as we go forward when treatments revert back to normal schedules, if they need to. I'd like to talk a bit more now about clinician welfare and the stress healthcare professionals are experiencing. A study I recently read found that over a third of healthcare workers in China during the peak of COVID-19 were reporting insomnia. It's an incredibly stressful time. How are you coping? How's your team coping?
Oh, well, thanks for asking. I think there has been a lot of focus on healthcare worker stress that I really haven't seen before. We know there's lots of stress in healthcare workers, high suicide rate, lots of depression. And there have been some issues with healthcare workers being spat upon, etc., because people thought they were transmitting COVID. But by and large, the community has been outstanding and has had newfound appreciation for healthcare workers. So on one way, we're feeling very valued, and there have been a lot of resources and activities to make sure there are resources to support healthcare workers. So within my team, we've had, first and foremost, the ability to work at home safely without compromising our patients. It has really compromised the other sort of patients, the PATIENCE, with some of the technology, but not our patients we treat. We've made plans, so that whole idea of being in control is helpful. As I mentioned last time, I believe the VCCC and MPCCC in Victoria, so the Victorian Comprehensive Cancer Centre and the Monash Partners equivalent, have formed a task force, and that's got an enormous number of resources, including resources for staff wellbeing and patient wellbeing. And we're only as good and relaxed as our patients are. If they're anxious or upset, we have to deal with that. So there's been a lot of resources developed on the fly, learning from some experiences overseas, but in some way what we're going through is not paralleled by what's happened overseas. We don't have that surge, and so we have a different sort of level of anxiety here about what have I missed out on, what will I continue to miss out on, almost questions that aren't asked if there's a huge panic and overwhelming, as we talked about, overwhelming competing risk of death staring you in the face in the community. We've got a slightly different problem there, facing a longer situation, longer, flatter course for this pandemic, and that's got different mental health and stress impacts as well.
Yes.
And healthcare workers are no different to others. They have stresses at home. There may be some in circumstances of domestic violence. People are now trying to cope with homeschooling children. So healthcare workers have those same issues as the general community. On a very personal note, I have to say, going into the hospital yesterday, walking through the thermal scanner, now with every patient, everybody screened and questionnaires, and with the lower rate being informed every day, how few patients there actually are in hospital with COVID-19, I personally feel a lot safer than several weeks ago, where it wasn't that we felt unsafe, we just felt uncertain about the future. I think there's a lot more certainty now of how this might impact on a day-to-day basis, not the fine detail, but the general milieu of how we will be practicing our medicine.
Oh, it's great that you're feeling safer in your working environment, and hopefully as things progress, people can feel more reassured in the hospital environment, and things will slowly but surely adjust to that kind of new normal. Is there anything that we can do to help? I know there was a survey you wanted to raise to your colleagues. We'd love to help share that.
Yes, so there's been a number of surveys sent around, and in fact, somebody did respond to me saying that they've listed the greatest stress in the survey of too many surveys coming out about how stressed we are. So there's suddenly a proliferation of research about how COVID-19 is impacting on patients, on carers, what cancer treatments have we changed. And one particular survey comes from one of our oncology colleagues, Photius Luparcus in northern Italy. And so we've disseminated that through social networking and our other contacts. There's an ESMO survey, particularly about cancer clinicians. And of course, there are also surveys now looking at how patients' treatments have been changed or impacted. So really looking at what the recommendations were. Again, they were broad guidelines. How were they applied? What actually happened to patients? And ultimately, of course, everybody is interested in the outcome of patients with non-COVID disease and how that's been impacted by COVID, and any lessons that we could learn for the future.
Yes, absolutely. It's incredibly important. We will include links to the surveys that you mentioned in the notes as well. So if anybody listening does want to participate and help that, that would be great.
I have to tell you the story of the function centre across the road from where I live, which obviously has closed down, put up a sign saying they were going to be catering meals at a very reasonable cost. And when we went to talk to them about it, it was to keep people on the job keeper salary, but also for some of their chefs who were not eligible for that. So we bought some dinner for my family, and it was so good we thought we'd try the other options the next night, and we went across and I'd emailed the order from my university email, and I got a text the next day from the owner of the centre who said that they'd like to provide free meals to all the Monash Health healthcare workers. And it took me a little while to work out how he even knew where I worked. And that's when I realised I'd sent it with an email signature. But these sort of things are extraordinary. And again, we're feeling, do we really deserve this? Because we haven't had this huge influx. But we're also very well aware of the impact of the economic impact on our patients, and particularly on patients where they're not able to work. If their family members have lost work or income, that's going to have a profound effect on them. And so we're now discussing whether we can have some meals provided to some cancer patients as well for free from this centre. So those sort of things are really quite extraordinary occurrences that were almost unfathomable 3 or 4 months ago.
Absolutely. I think the community coming together and all of these small random acts of kindness are very noticeable. My next question, Eva, is around healthcare professionals and their educational needs and how the lockdown restrictions on travel might affect that.
Yes, there's a lot of oncologists worried about their frequent flyer status. But in all seriousness, a major source of interaction with colleagues all over the world has been this culture of conferences, where not only do you learn the latest information and get to question presenters, but you interact with people from all over the world. And we really are a global community as oncologists. One-on-one, obviously, video conferencing is fine, or even a team of 30 or 40, but you can't get that interactivity for a conference such as ASCO or ESMO. We know that AACR, American Association of Cancer Research, just had their conference online, but it really is the presentations only. And certainly there's no hanging around posters and asking people about their what they're presenting, what they're doing next, all of that informal interaction that has been such a source of inspiration for future projects, collaborations, and friendships. So we're really going to miss that in the short term. We've got ASCO going online, and I'm sure we will watch the presentations and the analysis. But for example, Vogel, New York, standing up to ask a question as he does every year in all of the GI sessions, that won't happen. So it will be a time of adjustment for us. I am hearing, though, from many people, can we not talk about COVID at the moment? Can we look at what's going on in the cancer world and what has happened over the past few months that may not have got as much press as it otherwise would because of COVID, as well as obviously a lot of interest in cancer-related COVID-19 data. The issues of clinical trials and how they will report and how they will be impacted, again, is something that we want to watch this space for. So I think we will be doing lots of webinars and learning in a different way, but I do think there will be a loss of that amazing feeling when you're hearing data for the first time in an enormous hall and you're hearing questions from the audience. Whether we will go back to that or whether really those very mass events will not happen for a very long time is also another question. We are getting bombarded with emails and presentations. So I hope this podcast has been worth listening to, because picking a reliable source, finding information that is, useful when it's all coming in that one format is going to be a challenge.
Yes, discerning the most reliable information sources is a challenge because I think naturally, organizations working in oncology and other specialty areas want to do what they can to help support clinicians and healthcare professionals, provide as much information as possible. It's very much why we thought a podcast would be a good solution because it does start to become overwhelming. And this is something that hopefully you can listen to whilst you're, gardening or doing your washing up. It doesn't necessarily have to be sat at your computer in work mode. Was there anything else that you wanted to mention?
Look, just a shout out to the rural and regional cancer centres, and they're particularly relieved, I think, that this epidemic has not reached the heights of overwhelming the health service. They look after a lot of patients who live remotely, travel long distances, they have smaller workforces. So for the rural and regional centres, COVID-19 was always going to be a particular challenge. It's great that we've planned together and we've supported each other, and we will continue to do that. And making decisions for cancer patients in the absence of evidence, hard evidence, randomised trial evidence that we're so used to doing, but having reassurance from colleagues and people that we hold in esteem that this is a reasonable thing to do, or even having the options pointed out to us for us to consider and contextualise for our own practice and our own patients, I think has been valuable.
Yes, I think as we were talking before, the coming together of everybody doing what they can to support each other. And as we know, Australia has such diversity in oncology services, and what can be offered in regional centres is very different, and they have a unique set of challenges already. Thank you so much, Eva, for your very valuable time. I know you're busy.
Pleasure.
Um,
Thank you very much. I've enjoyed it and look forward to our weekly updates.
yes, we'll speak soon. Thank you.
Bye-bye.
You've been listening to the Oncology Podcast. If you enjoyed today's edition and would like to subscribe, head over to our website, oncologynews.com.au, and subscribe to our newsletter for weekly podcast updates and a review of the oncology news from Australia and around the world. Thank you for listening.